Good morning to all of you. Welcome to the Zoom webinar organized by GMOA and Society for Health Research and Innovation. We are glad to inform that each participant of the CPD webinar will be receiving an e-certificate for the participation. And please stay with us until the end of the session, and we'll be releasing the link in the chat box at the end of the session. So let's move to today's topic. Today's topic is approach to shortness of breath in the emergency department. To avoid interactions during the lecture, kindly mute your microphone and turn off the camera and use the chat box to clear your doubts using standard abbreviations at the end of the session. Now, it's my pleasure to introduce today's speaker, Dr. Dilan Epasinghe, consultant emergency physician currently attached to the District General Hospital, Kergal. Thank you for joining us today, and the floor is yours.
Thank you very much. Thank you very much for your kind introductions. Again, thank you very much for GMO and Shira to start in this sort of a lecture series. So I think very helpful. Today, my topic is approach to shortness of breath in the emergency department. I have selected this topic because there are two reasons for that. The first one is last time Dr. Beruguda Arachi, who has done the lecture on chest pain. So sort of continuation, I just want to do this topic. The second one is, it's very pathetic situation. Like, I think we are not properly managed shortness of breath in our department. I think this shortness of breath is basically corrupted in our departments. So we think that only two differential diagnoses like asthma or COPD and heart failure. So my approach is to give some introduction on shortness of breath, and we'll discuss some salient points in few situations. I think you can hear me and you can see the slides, right? If you have any doubts or any questions, just inbox the inbox, right? Okay. So shortness of breath, it's basically a lay term is air hunger. It's a difficulty in breathing. It's a subjective symptoms of breathlessness. So it's very unpleasant subjective sensation of abnormal respiration. Basically, it's normal in heavy exertion. Sorry? Hello? Yes? All right, okay. I think interruption, right? It's normal in heavy exertions, and it's pathological if it is occurring in unexpected situations. Like when you develop shortness of breath, when you are on lie down position or sitting position, that is very abnormal. So then and there you have to investigate on that, right? So then the reasons for shortness of breath, it's a dearrangement of oxygenation. You know that it's basically due to hypoxia and acidemia. However, it's a very complex phenomena. Result of stimulation of variety of mechanoreceptors starting from upper airway, lungs, and chest wall. So there is a hypoxia, sometimes invariably associated with acidosis. So that will stimulate your respiratory center and with this mechanoreceptors. So that is how you develop this shortness of breath. Right. Causes of dyspnea. There are four main types of causes. The first one is cardiac, the second one is pulmonary, third one is mixed cardiopulmonary, and fourth one is non-cardiopulmonary. So what are the examples for each and every one? So cardiac one, cardiac ischemia, congestive heart failure, dysarrhythmias, cardiomyopathies, carditis. Then pulmonary wise, asthma, pneumonia, pleural effusion, hemothorax, pneumothorax, interstitial lung disease, and COPD. Mixed cardiopulmonary is mechanical obstruction, complex congenital cardiopulmonary diseases. Non-cardiopulmonary causes like DKA, sepsis, psychogenics. So very important to understand there is a category called non-cardiac, and it's also very important for you to understand. Right, as an emergency doctor, the recognition is very important. So as you all know this method, so that is how we recognize everyone. This is the 5 steps we have to do: airway, breathing, circulation, disability, and exposure. So that is how we recognize the problem. So that is called MACA. So everyone should know about this thing: airway, breathing, circulation, disability, and exposure. Right. So when you go through this airway breathing, you can find red flags. If a patient can talk, or patient is in sort of a Cat 3 or Cat 4 situation, you can get a little bit of history from the patient or from the bystander. So history is very important here. History of chest pain or faintishness more related to the cardiac causes. History of congestive heart failure or congestive lung disease, then again you can categorize into heart or lung. History of trauma, yes, maybe hemothorax, many hypoxia, hypovolemia. Surgery, yes, maybe sepsis associated with recent sepsis or pulmonary embolism. Ongoing illness is very important to direct the patient towards cardiac or pulmonary, like hypertension, diabetes, bronchial asthma, COPD, etc. Then you can go again, airway breathing. Then if there is a secretion, then upper airway obstruction or swelling, then you can relate it to some upper airway obstruction related infection, or swelling may be due to allergic reaction or anaphylaxis. Patient is in grasping, it's basically pre-terminal situation. You have to then and there, you have to treat the patient. Likewise, bradycardia and apnea, yes, again pre-terminal. Respiratory distress. What are the features of respiratory distress? Using accessory muscles of respiration, tachypnea, restlessness, sweating, things like that. So shock, bradycardia, arrhythmias, again pre-terminal. You have to treat then and there. Fever suggestive of sepsis, cyanosis suggestive of hypoxia. Pallor may be due to again hypovolemia, rashes related to sepsis. So basically, you have to go through these salient points, red flags, and identify the patient's cause. That is very important. So how do you approach the patients? As I earlier said, you have to go through airway breathing circulation wise. First, you check whether the patient is responding or not. If patient is responding, it's okay, you can go after that. But if patient is not responding, you have to straight away start CPR. It's very important to start CPR, otherwise patient die. So start CPR if patient is not responding. Yes, if a patient is traumatic patient, you can go primary survey. So first of all, you have to suck out the secretion, prop up the patient and start oxygen. Then connect it to pulse oximetry or multipara monitors and check patient's saturation, blood pressure, and pulse rate. Then you have to cannulate the patient and take blood especially for VBG or ABG. It's very important. Then you can do the other investigations as well. Then disability wise, you can check the glucose level, GCS wise. It's very important. Then the temperature. Then you can do baseline investigation at your ward, like ECG, X-rays. If you have facilities to do ultrasound scan, that would be best thing. Then IV antibiotics, stat doses like aspirin, clopidogrel, then nebulize the patient. If a patient is in hypovolemic situation, then you have to start blood, sometimes or negative blood, and start straight away. Don't give fluid more. It's maximum of 1.5, not more than that. You can start blood. Once a patient is stabilized after your primary survey, then go for a secondary survey. Then secondary survey, you can do the whatever you want, like CT scan, other investigations, other examinations, like things. Then you can come to the rough diagnosis, and then you have to disposition the patient towards whether if you don't have facilities, then you have to transfer the patient, or whether you need to transfer this patient to the ICU. So that is what you have to do after the secondary survey. Investigations wise, blood investigation, definitely you have to do ABG and VPG, very important to check the patient's saturation, oxygenation, and carbon dioxide and bicarbonate level. Then the full blood count, CRP, blood sugar level, it's very important. Troponin D-dimers are very important as far as pulmonary embolism and ischemic heart disease is concerned. If you need, you can do renal function, liver functions, PTINR and APTT as well. Then the X-ray, important. Yes, basic chest X-ray. If it is a trauma, then you have 3 main X-rays. Nowadays, we don't do the C-spine, but chest X-ray, pelvic X-rays is very important. Then if you think about pulmonary embolism, yes, you can go for a CTPA or CT chest for trauma patients. Urine is very important to check the ketone bodies, sometimes urine fluid reports and culture. Bedside investigations are very important. I mean, it's not expensive and not time wasting. So ultrasound scan, bedside echo are very important. You know, fast scan, the special specificity and sensitivity is very high. So if you have facilities, try to learn those things. It's very important, and you can survive a lot of patients' life. Right. So after these things, I will explain few disease conditions, and I'm not giving A to Z sort of a thorough, explanations, but I will give some salient points, and this is very important to understand these salient points and do it. Right. First one is everyone knows about asthma. Asthma is a reversible bronchoconstriction. It's air block between the large airways to alveoli. As a result of that bronchoconstriction, there may not be have sort of air inside the alveoli, and alveoli may collapse. So patient may present with cyanosis, tachypnea, and sweating. There may be intercostal, subcostal recession, tracheal trunk, especially pediatric PET setup. Then you have rhonchi. It should be bilateral rhonchi if it is a sort of asthma. And patient may present with silent chest. You have to keep in mind, patient may present with silent chest. It is pre-terminal. If you don't do in minutes, patient may die. Then the tachycardia, low saturation, there may be hypotension as well. So the most important thing is this is a reversible bronchoconstriction, and there is an inflammatory process is going on. So you have to treat for those two things, right? So as for management wise, there are two things is very important. So you have to use bronchodilators to reverse the bronchoconstriction. So what are the bronchodilators we have? Salbutamol, ipratropium. Basically, those are the two things. In addition to that, we use met sulfate as well. Nowadays, we don't use theophylline much, but basically salbutamol and ipratropium are very important. In first hour, we can give 3 cycles, 20 minutes, 3 cycles of salbutamol and see the difference. After 1 hour, you can analyze the patient. The next thing is anti-inflammatory medications. As the name mentioned, it is a drug of choice for asthma patients. So anti-inflammatory are very important. We use steroids. A patient can't swallow, can start hydrocortisone, but if you can give prednisolone, that would be better. So maximum dose is 50 milligrams, 1 milligram per kg, right? And hydrocortisone also you can use if a patient is in, patient can't swallow the thing, right? So the most important thing is anti-inflammatory will take at least 4 hours to get their action. So meanwhile, you have to manage this patient with bronchodilators for 4 hours. So that is why it's very important to start anti-inflammatory early as possible. And then we'll take another 4 hours to get their action. So bronchodilators are, will reverse the situation, but not the treatment. Right? Then they treat the underlying infection, or if there is any allergic reaction, then you have to use adrenaline as well. Then the education is very important. So you have to understand that patient may develop this condition if there is any allergen or any food allergy or something like that. So you have to educate the patients very well. Then the disposition. There are 3 places you can send. The first one is you can send this patient to the ICU if the patient's condition is not improving. The second one is you can send the patient to the ward for further nebulization and further management continuation. Otherwise, you can discharge the patient. You can discharge the patient and ask patient to come to the clinic. So imagine after about 4 hours, patient symptoms are okay. That means that the patient's anti-inflammatory drugs will start to act. So then that point, patient is okay. Then patient, you can discharge the patient and ask them to come to the clinic. So next topic is irreversible situation. This is called chronic obstructive pulmonary disease. The symptoms like exertional breathlessness, chronic of regular sputum production, and wheezing. So sometimes patient may have history of, most of the time, I mean about 90% of the time patient have history of smoking. So those are the things, and these are the clinical features. Marked dyspnea is there, and tachypnea, pursed lip breathing is there, use of accessory muscles, acute confusional state because of carbon dioxide retention, and new onset peripheral edema. There are two reasons for that. First one is right heart failure. The second one is there may be hypoalbuminemia because of this sputum production. So the hypoalbuminemia may associate, hyperproteinemia may associate with peripheral edema. So how do you manage these patients? You can go according to the British Thoracic Society guideline. So you can give oxygen. You have to be very careful when you use oxygen for patient with COPD. Try to keep saturation up to about 92. That is more than enough for these patients. And you can use bronchodilators like salbutamol, protropium. These patients, we can use theophylline as well. You can give a trial of steroid, even though this is not a inflammatory situation, but sometimes patient may work with steroid. So you can give, same dose as asthma, prednisolone or steroid, hydrocortisone. The next part is very important: antibiotics. These patients are having sort of a chronic illness over a few years, right? And patient may have some atypical bacterial infections like mycoplasma or legionella. So you have to cover these patients with something like erythromycin or doxycycline. So you can use antibiotics as well in addition to normal antibiotics you use. Right. The next topic is pulmonary edema. This is the problem is muscles, cardiac muscles can't contract well due to poor stretchability. The reasons for that is ischemic heart disease, arrhythmias, hypertension, cardiomyopathy. There may be infections as well. The problem is cardiac oxygen demand exceed the availability. As a result of that, there is a hypoxia and acidosis. Air can't cross the blood interface, so there is no carbon dioxide oxygen gas exchange. Fluid seeps from the blood into the alveoli. As a result of that, there is a fluid inside the alveoli and no place to exchange the gas. So surfactant get diluted and caused by cardiac and vascular dearrangement. It's sort of a vicious cycle. Some or other we have to, stop one stage at this cycle. So that is how you treat the pulmonary edema. So basic of treating pulmonary edema is you have to prop up the patient and start oxygen. Keep saturation somewhere less than 95 in this case situation, because oxygen is a pulmonary vasodilator. So when you give more oxygen, that will dilate your pulmonary vessels and more fluid retention is there. So that will act as a negative effect on the heart failure. So don't give too much of oxygen. Try to keep saturation about 92, 93 is more than enough for heart failure patient. Then you have to start two things. The first one is GTN infusion. If blood pressure is about 100, more than 110, you can start small dose of GTN, like 5 mics per kg per minute. Or, its book says it's about 100, but I don't think it's practicable in our setup. Probably about 110 is okay. So just try to start GTN. GTN is very short-acting vasodilator. So when you stop, will take about maximum couple of minutes to disappear its action. So don't worry about the hypotension. So start minimum dose of GTN infusion if blood pressure is more than 110. But if it is less than 100, don't start GTN infusion. The second one is CPAP. CPAP means what you do is CPAP will recruit your alveoli and it will push down your fluid inside the alveoli, and it will increase your surface area of alveoli. As a result of that, there is a place for gas exchange, right? So this is very important to know that don't give too much fluid, oxygen, and GTN infusion and CPAP is very important in heart failure. Furosemide, we used to give furosemide, but nowadays we don't give furosemide because the only reason is like furosemide will take about 20 minutes to its action. So for 20 minutes is a very critical period for heart failure patients. So if you don't have anything, yes, you don't have a CPAP machine, you don't have a GTN, yes, you can start furosemide, but please remember, if you have those facilities, don't give furosemide straight away. You can use furosemide if your blood pressure is low, about 100. So you can start furosemide infusion 1 or 2 milligrams per hour, like very small infusion, but don't give much furosemide for patients with heart failure as a first choice, right? Then the second one is you have to restrict the fluids, somewhere around 1,000 to 1.5 liters per day. So it is very important to restrict fluids because the problem is preload. That's why we start dilators and things and reduce the preload. The other problem is the muscle itself. So in that case, we can start inotropes as well. But the thing is, you have to treat for the cause. So heart failure doesn't come straight away, and you have to do something for that. So the treatment for its precipitating factors. So what are the precipitating factors? Ischemic heart disease, then you have to start thrombolysis and primary PCI if you have facilities. But most of the teaching hospital have got cath lab, but I don't think it's general hospital. So basically what you can do is you have to start thrombolysis then and there within reasonable period of time. There is any arrhythmias, then and patient's blood pressure is low, hypo, patient is unstable, then you have to go for a cardioversion, mainly electrical cardioversion. Otherwise, yes, you can go for a chemical cardioversion. Antihypertensives, the patient develop hypertensive pulmonary edema, you can start GTN infusion. Apart from that, ABCD means ACE inhibitors, beta blockers, calcium channel blockers, and diuretics start for the hypertension. Inotropes is very important. As I earlier mentioned, it's a problem with the muscles, stretchability is reduced. So what you can do is we can start positive inotropes like dobutamine for these patients. The problem with inotrope is it will increase your heart rate and oxygen consumption. So try to give it minimum doses, otherwise it will increase your heart rate. But in case of myocarditis, you have to start inotropes and be careful with other medications and fluid. Antibiotics. So sometimes in sepsis, there may be a cytotoxic effect on heart. So in that case, yes, you need to start antibiotics as well. Referral is very important for these patients, especially when you work in an emergency department. So cardiac referral is very important. You can ask, the facilities for PCI, and it's very important. Then the disposition, as I earlier mentioned, ICU, HDU, ward. I don't think this patient you can discharge on that day, but keep in mind that it's very important to arrange other facilities for these patients like thrombolysis, PCI, in case of, cardioversions, very important. These are the skills you have to develop at your level in the emergency department, like cardioversion, electrical cardioversions is very important, resuscitation, and starting inotropes is very important. It's not a topic to discuss about inotrope, but it's very important to read about inotropes as well. Next topic is very common topics is pneumonia. Nowadays, it's very common. Infection in the lower airway, it's associated with consolidation. Consolidation means fluid in the alveoli. Fluid means it's basically pus inside the alveoli. Often only one part of a lung is associated, involved. But if you take atypical pneumonia, like, in COVID infections, both lungs are involved. You can see patchy consolidation all over the lungs, and you can hear the crepitations all over the lung on both sides. The problem with the fever here is, like, fever increase the metabolic demands of oxygenation, and as a result of that, your respiratory rate is increased more. So lethargy, cough may associate with hemoptysis, chest pain, then atypical features like diarrhea, body ache. These are the other features associated with pneumonia. Treatment-wise, antibiotic if bacterial, and you have to think about atypical phenomenon, atypical bacteria as well, Mycoplasma, Legionella, things like that. And then you have to start symptomatic treatment like paracetamol, bronchodilators. Nowadays, it's COVID infections, symptomatic treatments is very important for these patients because we don't have any treatment for COVID infection. Non-invasive ventilation or mechanical ventilation if needed. In that situation, we have to send the patient to the HDU, ICU. I just want to emphasize a few details about COVID-19 nowadays. It's very important to identify the COVID hypoxia as early as possible. So in that situations, you can treat with nasal prone oxygen or even mask. But when the saturation dropped up to less than about 80 to 70, it's very difficult to deal with the patient. So it's very, very difficult situation. Even with CPAP or intubation, you can't succeed. That's the problem with the COVID situation. I know the situation is very bad here. Monitoring facilities are, very difficult to do these days, but still try to catch up, hypoxia as early as possible, at least in young patients. Then the sepsis. Sepsis is not only pneumonia, but also, abdominal sepsis, necrotizing fasciitis, and that sort of sepsis. So what you have to do is you have to follow the sepsis bundle, 1 hour bundle, 4 hour bundle, likewise. So treat the patient as early as possible. That's how you can, cure the patient. So start antibiotics early as possible. IV fluids, if MAP is less than 60, start vasopressors. The symptomatic treatments, as I said, sometimes you can use hydrocortisone, bronchodilators, as earlier said, that sort of a medication you can use as a symptomatic treatment. The most important thing is recognition and treat early as possible. If you late, then it's very difficult to get rid of the problem, even with the enough facilities. Next topic is surgical, very important, and that's why I earlier said you have to develop skills when you work in the emergency department. This is pneumo or hemothorax. Air or blood stuff gets between the inside of the chest wall and the lung. You call parietal and visceral pleura, between parietal and visceral pleura. So it's an acute surgical emergency. There are 3 conditions. The first one is tension pneumothorax, open pneumothorax, and massive pneumothorax. Tension pneumothorax means air collect inside the pleural and pleural cavity, and you can get severe emergency situations like hypotension, dyspnea, hypoxia, tachycardia, source of picture. So then and there you have to treat the patient, otherwise patient will die within minutes. Open pneumothorax means like there is a wound which act as a sort of a valve. As a result of that, air comes through that wound and collect inside the pleural cavity. Then the massive hemothorax means blood inside the pleural cavity. The collection is more than 1,000 milliliters, 1 liter. The problem is there is two things: hypovolemic shock and then the obstructions as well. So you have to treat the patients accordingly. So how do you treat? If a patient with pneumo or hemothorax presents with the history of trauma, chest trauma, straight away you can do the finger thoracotomy. Nowadays, this is the management. You can put your finger and make a hole both side of the chest, and no need to put any tubes or anything until you stabilize the patient. Just put your finger in the second intercostal space, or sorry, in the fourth intercostal space, and just stabilize the patient. But imagine if a spontaneous pneumothorax who present is, with tension, then what you can do is you can put a white bone needle inside the anterior chest wall, its second intercostal space at the midline of the clavicle. Then open pneumothorax, what you can do is you can block the valve effect. So what you can do is you apply a plaster. It is called 3-side plaster on the chest. Right. So then ultimately for the anything, pneumothorax, hemothorax, or even open pneumothorax, you can put a IC tube. Once a patient stabilized, especially for trauma patient, then you can put this IC tube. Right. This pulmonary embolism, next topic. I think pulmonary embolism is a very rare condition in Sri Lanka. I don't know whether it's rare or we are not investigation properly for these patients. Anyway, it's a blood clot inside the pulmonary circulation blocks, especially venous circulation. The symptoms are hypoxia, tachycardia, tachypnea, sometimes chest pain. It's sort of pleuritic type chest pain associated with long travels, history of venous thrombosis, and OCP. We are patient with if you have an OCP, there is a high chance of getting OCP. So how do you diagnose this patient clinically? You can go through this scoring system. First one is Wells score, and then the Perks rule. So you can exclude with this scoring system, and then you can go for the other baseline investigations like D-dimers and CTPA. So treatment-wise, you can start oxygen and anticoagulations like enoxaparin, and then you can start TPA for thrombolysis. Right. This is non-cardiopulmonary conditions. It's a very important situation in Sri Lanka because nowadays you can get a lot of pediatric patients with diabetic ketoacidosis. Then you have to be very equipped with diabetic right? So we have two management plan for both adults and pediatrics, but the basic management plan is the same, right? Diabetic ketoacidosis associated tachypnea often without air hunger. You can understand that they have tachypnea without any lung features or intercostal subcostal recessions or something like that. They are basically not hypoxic unless patient has got something like pneumonia or that sort of infection inside the lung, because pneumonia can precipitate diabetic ketoacidosis, or even lung injuries can precipitate diabetes unless they don't have hypoxia or other lung features. They have polyuria, polydipsia, loss of weight, and dehydration. How do you diagnose diabetic ketoacidosis? There are three things to fulfill. The first one is history of diabetes or hyperglycemia. Blood glucose level is more than 11 millimoles per liter. The second one is acidosis. Either metabolic acidosis pH is less than 7.3 or bicarbonate level is less than 15 millimoles per liter. Third one is ketosis, either blood ketonemia or urine ketone bodies. So either of them you can use. So if these three things are there, that is diabetic ketoacidosis. So how do you manage the patient? There are three salient steps. The first one is stop ketone productions. The second one is treat for underlying causes. Third one is prevent from complications. Stop ketone production by starting insulin. You can use 0.5 units per kg per hour. So very important to understand that we use insulin to stop ketone production and stop acidosis rather than glucose level, hyperglycemia. Yes, hyperglycemia will reduce with insulin, but the main target is to reduce ketone production. So usually we reduce 50 to 70 milligrams per deciliters per hour, not more than that. If you reduce more than that, then that will increase your cerebral edema. So you have to be very careful when you start in insulin and reducing glucose level. Then the treat for underlying or precipitating factors. There may be infection. You have to start antibiotics. Then you have to do blood culture and things like that. Then there may be ischemic heart disease, sometimes myocardial infarctions. Then you have to treat for that as well. Then the stroke. Yes, stroke can cause, can precipitate diabetic ketoacidosis. Then you have to treat for that if the patient present with that time frame. Prevent from the complication. The most important two complications are there. The first one is hypokalemia. Hypokalemia. When you start insulin for a patient with hyperglycemia, their potassium level will come down. So be careful with that and check potassium level at least every 2 hours. Then the cerebral edema is very important. That's why we have this protocol to give fluid sort of a rational way and reduce glucose very rational way. Otherwise, patient may die with this cerebral edema. So we have to be very careful, especially for adults and children. Yeah, children as well. Monitoring is very important for these patients. Not only basic pulse rate, blood pressure, things like that, but on the other hand, blood sugar level, pH, and electrolyte level as well. When to stop insulin is very important. So you don't stop insulin. Imagine if blood sugar level is normal or if blood sugar level is 200. You have to think about the other levels as well. The glucose level is less than 200. The pH should be greater than 7.3. So this is the normal level. It should be more than 7.3. And the bicarbonate level is 18 or more than that. So otherwise, you don't stop insulin. You have to give insulin with 5% dextrose to stop acidemia and ketone production. So it's very important to understand this thing. Right. Next topic is poisoning. There are two poisoning you can get this near, that carbon monoxide poisoning and cyanide poisoning. Carbon monoxide poisoning because of hypoxia. It's a competitive inhibitor of oxygen binding at hemoglobin site. You know that it's basically irreversibly bind to the hemoglobin site. So as a result of that, there is a carbon monoxide, there is hypoxia. Treatment wise, overwhelm the carbon dioxide with 100% oxygen, or if it is not responding, you have to use hyperbaric oxygen. It's other things you have to know about this. Hyperbaric oxygen centers are very few in Sri Lanka. One is in probably in Trincomalee. The other one is I think in somewhere there in Colombo. I can't remember, but it's very few centers are there. So it's very difficult to manage carbon monoxide poisoning if it is highly toxic situation. The next poison is cyanide poisoning. The inhibition of oxygen utilization at the cellular level. Even though you have plenty of oxygen in the air, in the blood, cell can't utilize that oxygen because of cyanide poisoning. Management wise, that it's time critical situation. So most of the time patient will die. and even after presentations, I mean, it's very difficult to, cure the patient. This is the last topic I want to emphasize you. The first one is psychogenic dyspnea. Please keep in your mind. So psychogenic dyspnea, patient may present with dyspnea without any lung signs, right? That is due to anxiety, right? Sometimes panic disorders. But keep in mind that there are other conditions as well, drug withdrawal and hallucinations. So drug withdrawal is very important for these patients. So if the patient presents with dyspnea with drug withdrawal situation, their blood pressure may be very high, and sometimes their pulse rate is very high, and they have the sweating and reduced level of consciousness. So it's the fate of mortality rate is very high in this situation. So these patients. So please try to do something these patients as soon as possible. Just don't forget about these patients. Just say that these are psychogenic and nothing to say. So just check their blood pressure, check their pulse rate, check whether there is any hypoglycemic situations. So these are the things you have to remember. The next thing is this may be the first episode of psychiatric disorders like schizophrenia or bipolar disorder. Patient is probably having some hallucinations. Patient is scared of that hallucination and having sort of a anxiety on that. So just try to clarify, just try to figure it out, whether it's due to anxiety or hallucination or drug withdrawal. It's very important to treat this patient, otherwise patient will die. Right. Okay, any questions? Right, few questions.
Thank you very much for that excellent presentation. We have quite a number of questions from the participants. I think I'll repeat the questions to you so that it's easy for you to answer.
Okay.
And the first question is it recommended to give IV salbutamol? And they cause arrhythmias?
Yes, you can start a small dose of IV salbutamol, probably about 1 mics per kg per minute, and then increase up to probably about 5. But the problem is when you give more than 3 mics, the patient should be in the ICU. I mean, don't give more than that when a patient is in the emergency department. So monitoring is very important. Yes, the patient can get arrhythmias. That's why we want to send this patient to the ICU.
Thank you, sir. And the next question is, you have already explained this, but just to highlight, what is the current guideline in practice on heart failure management?
The problem is still we don't have a proper guideline system in Sri Lanka. We have, first one is emergency medicine guideline is there. It's published in 2017. I think it's also said that use furosemide, but when you go to the NICE guideline or even in the other guidelines, you can use that guideline. But Sri Lanka, we don't have proper guidelines. When you need any sort of a guidelines, please go to European Resuscitation Council guidelines or a NICE guideline. That's it.
Thank you, sir. And there's one more question in that, is the first line inotropic agent in acute heart failure? I mean, they ask me what is the first line inotropic agent in acute heart failure and what is the place of noradrenaline in acute heart failure?
Yes, first inotropy should be, dobutamine. When you increase dobutamine, the problem is you can get high heart rate level, heart rate. So that is a problem. But apart from that, you can start noradrenaline small dose. But my choice is like, you can start dobutamine first, and then you can combine with a small dose of noradrenaline.
Thank you, sir. And one more question on what are the difference in treatment between acute and chronic heart failure?
we are treat the pulmonary edema and low saturation, like, basically we have to treat for the acute heart failure. That is the most important thing, and fate mortality is very high. So chronic heart failure is heart modification drugs you use as there are a few more life heart modification medications like ACE inhibitors, beta blockers, and things like that. But chronic acute heart failure, yes, first one is you have to reduce the preload and recruit your bronchioles. So that's why we need GTN and CPAP. But chronic heart failure, I think you are asking acute versus chronic, not asking acute versus acute on chronic, right? So acute on chronic, yes, definitely you have acute on chronic, you have to treat for the acute heart failure. Then the heart modification medications like ACE inhibitors, beta blockers, you can use with some furosemide or some diuretics.
Thank you, sir. And the next question is, if an asthma patient comes with acute asthma but is also having a COVID, how can we treat, and can we still give prednisolone?
You know that we use dexamethasone in, nowadays we call it as CHOPSY. After day 5, patient develop hypoxia with hypoxia means saturation is less than 95. With dyspnea, you use CHOPSY. CHOPSY includes 4 things: dexamethasone 8 milligrams, then ceftriaxone, enoxaparin, and sometimes we use clarithromycin as well. So in that situation, we use dexamethasone as an anti-inflammatory medications. But apart from that, if a patient has got some bronchi, yes, definitely you can use salbutamol in nebulization, nebulization or inhalation. So definitely you can use it. And but apart from that, hydrocortisone or prednisolone we don't use, because we already started dexamethasone and we have to give it for about, I think, 4 or 5 days.
Thank you very much, sir. Sir, please bear with us. We are getting more questions from the participants. And the next question is, what is the exact pathophysiology of COVID pneumonia? Is it acute pneumonitis, kind of immune-mediated?
So I'm not expert in, I haven't done any research on that, but according to my knowledge, and I heard from a few lectures, for first couple of days, you are getting viremia because of the COVID infection. So body will react to that viremia by act like as you increase your inflammatory markers. So leukotrienes will increase in your body. Sometimes that can go sort of a hyper reaction. So as a result of that, you can get most likely it's a pneumonitis, immune-mediated pneumonitis. That's what they said. So after about 4 days, patient develop, dyspnea, features of pneumonia. That is called, most likely it's immune-mediated pneumonitis. So that's why we use dexamethasone, enoxaparin, and sometimes that condition will secondary infected with the bacteria. So that's why we use ceftriaxone. So basically it's immune-mediated pneumonitis, but no one knows the real pathology up to now. But they say it's most researchers and predictors say that it's basically immune-mediated pneumonitis.
Thank you, sir. That was a great explanation. And the next question is, what is the placement of needle in needle thoracosynthesis? Is it a second intercostal space or safe triangle?
No, it's the thing. The reason is you put the white wood needle cannula into the second intercostal space in the case of pneumothorax, right? So if it is pneumothorax, yes, definitely it should be in the second intercostal space. Safe triangle is to put your IC tube and your finger thoracotomy, right? So basically, placement of needle in needle thoracotomy in the second intercostal space rather than the safe triangle, right? So if you want to put the IC tube or your finger, yes, definitely in your safe triangle, not in the second intercostal space.
Thank you, sir. We have got few more questions in DKA. How does a DKA patient develop cerebral edema? What is the pathophysiology there? Can you please explain? And in the same topic, we got how does more insulin can worsen the cerebral edema in DKA?
Yeah, the thing is this, like, DK patients, the hyperglycemia are not a sudden onset procedure. So it has been there for some time. So your brain cells are used to the situations, like with hyperglycemic situations. When you give more insulin, or if you reduce insulin suddenly, what will happen is they will shrink. As a result of that, they will take more fluid inside into the neuron cells. Then they will get swollen, right? So that's what happened. So that's why you want to give it sort of a symptomatic, sort of a systematic way. Otherwise, if you reduce suddenly, what will happen is all cells swollen and get swelled. So that's what happened in cerebral edema. Don't give more fluids, or don't reduce glucose sort of rapidly. That's the two things we have to keep in your mind. That's why we want to give fluid in a separate sort of systematical way. Like, first hour 1 liter, second hour 2 liters, likewise. First 2 hours, 2 liters, then 4 liters. Likewise, we have to give it. Otherwise, the cell get swollen, and then as a result of that, there is a swelling. The next question is, does more insulin can worsen? Yes, that's what I say. Like, if you give more insulin, what will happen is you will reduce your glucose level suddenly, right? So then that's what happened. So then glucose come out, and there will be a sort of swelling. The most important thing is we don't give insulin to reduce. We give insulin to reduce glucose, but the most important thing is we want to reduce the acidemia and bicarbonate productions. Sorry, ketone body production. That is why we want to give insulin and reduce the acidemia rather than reducing the blood glucose level.
Thank you, sir. And the next question is from carbon monoxide poisoning. As partial pressure of oxygen is normal in the carbon monoxide poisoning, can it cause dyspnea?
So the dyspnea can associate with two things, as I earlier mentioned, the hypoxia and acidosis. If there is no hypoxia or acidosis, I mean, no one can stimulate your respiratory center. So then there won't be any dyspnea. But if there is hypoxia or carbon dioxide, acidosis, then definitely there is increase your respiratory. They will stimulate your respiratory center and increase your respiratory rate. Yes, the problem is if there is no hypoxia, I don't think they can stimulate your respiratory center.
Thank you, sir. We have got few more questions, sir. What type of hypoxia we develop in COVID?
Hypoxia may be associated with it's called hypoxic hypoxia, because this COVID problem increase your as I earlier said, inflammatory markers, and there is condition called respiratory ARDS, acute respiratory distress syndrome. So as a result of that, there is a fluid and there is a poor VQ mismatch, right? So that is how they will get the hypoxia. The carbon dioxide oxygen exchange is very low. So that's what happened in COVID as well. So it's basically hypoxic hypoxia due to poor VQ mismatch.
Thank you, sir. The other questions we have already explained, but a few more to find out, sir. What is the action of GTN in heart failure? And what is the immediate action of furosemide in heart failure? Is it venodilate or diuresis?
Yes, the first one is GTN is a venodilator. So that is how you reduce your preload. So reduced preload means you can have you can reduce your pulmonary edema as well. Furosemide is a first action is a arteriodilator, so that is how they will they get the response. But the problem is it takes some time, so at least about 15-20 minutes will take to get the action. So that is the reason you don't nowadays you don't use furosemide as a first line treatment.
Thank you very much, sir. That's all the questions for today. Thank you very much, sir, for that excellent presentation. And I really thank you on behalf of GMOA and Society for Health Research and Innovation, spending your valuable time here today with us, sir. And also, we would like to present your token of appreciation. I think that will reach you in few days. And thank you very much, sir. Thank you very much again. And thank you all for the participation. Please follow the link in the chat box to receive your participation certificate. That's the end of the webinar. We'll be keeping the Zoom meeting for some time for you all to fill the Google form for the participation certificate. You can please find the link in the chat box. So that's the end of the webinar today. Thank you all again. And I'm Dr. Sinta signing off. Thank you. Have a good day.
Thank you very much.
Thank you so much, sir.